So we're hanging out with Dr. Sam Dawson-Tandy today, and the conversation is about pelvic floor dysfunction. And we're really going to try to target this, maybe if we can, a little bit towards weightlifters, powerlifters, but by all means, CrossFitters, active individual who likes to use weight training, that all applies. And so I'm really looking forward to this discussion because this is an area that I know very little about. Yet I hear quite a bit about. And so if you want, Sam, can you just take a second to sort of introduce yourself, give like a brief rundown of your background, and then we'll just kind of roll into some questions?
Yeah.
Awesome.
So I'm Sam. My real name's Samantha, but that's too formal for me. I'm what you would call a pelvic floor specialist. I'm a PT by training, and in PT school, I was just trying to figure out what I wanted to do, and I heard about this specialty, and I shadowed a few PTs at the U, actually, the University of Utah.
Yeah.
And like the first second I started shadowing, I was like, I have to do this for sure. So
Nice.
I did a full-time internship in it. I was hired by the company, so it's a private practice in the Valley. And then I kind of went through a mentorship. I've taken multiple continuing ed courses because you don't learn a ton of stuff on how to do this in PT school. So it's kind of up to you to become your own specialist, I suppose. And that's kind of I've been doing it for almost 2 years now.
Okay, cool.
Yeah.
One of the reasons why I was really excited to chat with you is because you have been endorsed as highly curious and highly nerdy. And that immediately makes me want to have this conversation with you. And so I really am excited to go through some of these questions to get some information from you.
Yeah.
So I think first, maybe just a good starting point is, what is the pelvic floor and what should we know about it, just at face value?
Yeah, so the pelvic floor is, the most underrated muscle group in the body. Like pretty much no one knows they have one. And I always explain to people that's part of its function. Like you don't need to think about it all the time. That would be so exhausting and annoying to think like, oh, I need to contract. Oh, relax, contract, relax. So I don't fault anyone for not knowing they have a pelvic floor. But basically, to put it short, it's the undercarriage of our trunk and of our body. I mean, before the legs split off from the pelvis, it's really just a sling of muscles, basically, that perform a variety of roles in our function. So, it has kind of 3 main functions. I actually have my little model here. I brought it from work today.
Oh, yes. I love it.
I will models. Say it's a female model. So there's some obvious like anatomical changes for men. But this is, our pelvis. Yeah. And here's the top view of the pelvic floor, the bottom view.
Okay.
So it has 3 main functions. So the first function is support. So, and this is where it kind of branches for male and female sexes, but it supports our 3 pelvic organs for females, for men too. So the rectum sits in the back near the tailbone, the vaginal canal, cervix, uterus, ovaries, that stuff in the middle, and then the bladder is in the front. So this, you can kind of see how this is oriented. It literally looks like a hammock. And this group of muscles is called the levator ani group. And main supportive role, because really beyond here, there's no bony support happening. It's all muscular and ligaments, tendons, fascia. So that's the first role. The second role is that it's sphincteric. So towards like the superficial layer of muscles, they're circular in nature. So sphincter muscles are just circular muscles, and when they contract, they close an opening. So we have them all in our face, and then through our GI tract, and then a bunch of them are in our pelvic floor. So that's what keeps us continent, or keeps things in that we want in, and lets them out when we want to let them out. And then the the third function is that it aids in sexual function. So the pelvic floor muscles are really responsive to the arousal cycle. So yeah, and kind of when people have a pelvic floor dysfunction, their symptoms kind of lie in one of these like main functions of the pelvic floor. And also one kind of like secondary function that should not be forgotten is it's part of the core floor. So it's a fourth of your core musculature. The other three being your abdominal wall in the front, the diaphragm on the top, and then the multifidi in the low back.
So really quickly, you said that the pelvic floor muscles respond to sexual function. Can you tell me what you mean when you say respond? What are we talking about?
Yeah. So when any human is aroused, I'm not sure about animals. My sister's a vet. I would have to ask her this, but yeah. So men and women, when we are aroused, our pelvic floor starts to contract, kind of in this like repetitive motion. Most of us aren't really focused on that, so no one really knows what's happening. And what that does is it shunts blood to the erectile tissue. So for men, that's the penis; for women, the clitoris. And so it's kind of like a root cause of how that blood gets shunted to those two organs. And then during orgasm, the pelvic floor muscles like repetitively contract, kind of like in a pulsating motion. And so sometimes people, like I treat erectile dysfunction. Sometimes people come in and it's like part of their story. I don't see it a lot in women that like they come because they have difficulty achieving orgasm, but it's definitely like in the list of things that happens when you have like weak muscles or tight muscles. So
that's almost like that almost perfectly brings me to my question. So what is dysfunction? How would you describe dysfunction? You've kind of already alluded to it a little bit, but how would you describe it, and how does somebody know? I guess the same question is, how does somebody know whether they have pelvic floor dysfunction, men and women?
Yeah. So dysfunction it's literally just an umbrella term that people have kind of come up with to describe what we treat, and it's still not even a really great term. Like it sucks to be like a patient come in and be like, you have a dysfunction, and you're like, great. So however you want to describe it, but that's usually what we call it, a dysfunction. So the most common ones are, if you just think of like muscular physiology, is that there's weakness, coordination, timing, motor control problems. That usually leads to incontinence, like urinary fecal gas incontinence. It can play a role in pelvic organ prolapse. So the pelvic floor is not the only thing that causes pelvic organ prolapse, but it's how we treat it with PT.
Can you describe pelvic organ prolapse?
Organ prolapse? Yeah, of course. So basically, one myth is that it only happens in women who've had babies, and that's not always true. It's the biggest population of people who have prolapse, but I can't think of it off the top of my head, but there's some crazy statistic that like 90% of women who've had babies have prolapse at some point. But basically it's a failure of the systems holding up the organs. There's really three main anatomical things that hold the organs up. So there's ligamentous support. So especially with the uterus and the bladder, there's ligaments that are attached to the pelvic wall, the sides of the pelvic wall. Then there is muscular support. That's a whole third of the problem with prolapse sometimes. So back to like the main function. Muscular support. And then the third is actually, for women at least, is integrity of the vaginal canal tissue. So like when you push something out as big as a full-term baby, you know, the tissue can just get compromised because it has to stretch, and tearing like perineal tearing during childbirth really plays a role in this as well.
Okay.
So one of those three things is usually what's causing prolapse. So with PT, you can imagine we can't really change the ligaments too much. We can't like sprinkle magical powder and make them, get taut again and hold the bladder or uterus or whatever up. And we can't really change the tissue integrity of the vaginal canal, but we can change the muscle activation and coordination.
Okay.
So
the muscles that help the ligaments to help provide that support. Okay.
Yeah, absolutely.
Okay.
And kind of just reminding yourself, the muscles don't just like turn on, turn off. They're kind of like, they should be in this like middle zone. That's how I explain it to my patients of like, we want you to be like here where they can contract when they need, but they can relax when they need, but they still have tone. You kind of think of it like your abdominal wall. Like there's always a little bit of tone in the muscles. You don't have to tell them to activate to keep you upright. That's kind of how the pelvic floor should act.
Okay.
So yeah, back to dysfunction. So there's like that whole aspect of it. Mm-hmm. And then there can be this whole realm of disorder or like issues with a pelvic floor that doesn't relax well. And that's really, really common. Mm-hmm.
Okay. That being really common, that is much less common, I think, in terms of, general knowledge base. I don't think people are commonly within the strength and conditioning athletic communities are not really talking about overactivity. It's mostly, well, it's weak, so let's strengthen it. So to hear that it's common that it's overactive, that's interesting. So then what you're saying is that if we were to go down the route of like Kegels, for a case where we have an overactive pelvic floor, would that be counterproductive?
It usually is. Or it's just like, sometimes I have people that come in and they're like, I can't do a Kegel. And it's because their muscles are so tight that there's like no room for the muscles to actually shorten further.
Interesting.
And so sometimes weakness can be masked as like, actually it's like muscle overactivity. So,
I wonder how this plays out with the pelvic floor, but it's not uncommon just in general orthopedics that you have an overactive muscle that is also weak. Mm-hmm. So that makes that a little bit more complicated. So is your suggestion that, first of all, can that be the case with the pelvic floor? Can you have overactivity and weakness?
Yes, and that's why I have a job. Because it's more complicated than most people give it.
You might have to work on, and I assume this is all over the place in terms of how this would progress, but you might have to work on the overactivity before you can get to an effective strengthening exercise. But at the end of the day, we're not always doing Kegels. We're not always trying to get stronger. That's kind of what I'm taking away from this. And I think that's, maybe just the fact that strength athletes, they think that everything's due to weakness. But perhaps that's maybe not the case. Interesting.
Yeah, probably the biggest myth I could bust today is that Kegels are like it's not the only, and if you try them, that's totally fine. You can try them, but if they don't help, then you should see a specialist. So.
Okay. So you think that the case is, let's say Kegels are in effect, they're not targeting the tissue, they're not seeing an improvement. It's not easy enough to just say, what's the next option? There's a lot more thorough evaluation required before the next option's presented. That kind of where your thoughts are? Okay. More job security there, huh?
Yeah, totally.
Yeah, for sure. There's, first of all, I heard erectile dysfunction, and I'm thinking, okay, so erectile dysfunction can be caused by a pelvic floor problem in men. So for men, we're not just thinking that that's something that a pill needs to solve. We may actually have a pelvic floor dysfunction. That's interesting.
Yeah, it's not always. Erectile dysfunction is definitely a little more complicated.
Okay.
I think the last literature I read said that like 80% of erectile dysfunction is usually the signs of an underlying systemic disorder. So like neurovasculature, nervous, but it's worth trying pelvic PT if there is an option for that to be solved.
Yeah, I did a video where I tried to convince powerlifters to do cardio, and my argument was the relationship between poor cardiovascular health and erectile dysfunction. I still don't know if anybody took it home, but I thought that was going to be.
I love
I
that.
thought that would be all it would take, but I don't know. Maybe
That's
not.
good marketing.
Yeah. Is there any here's what I'm wondering. I think the number one complaint I hear about is just, it's considered normal. I'll just say that within these conversations that I've had to the athletes, is that, female athletes doing heavy weight training, maybe we're talking about CrossFit, maybe we're talking about Olympic weightlifting. So think about like the weightlifting you see on TV, like a clean and jerk where somebody's pulling, throwing a bar overhead, or powerlifting where we're just trying to lift as much weight as possible, not necessarily concerned as much about speed during performance. I think a very common complaint is leakage from the female athletes during these lifts. So, and so much so that in some circles, I've had some conversations with CrossFit athletes that have said, yeah, it's just we just sort of go to the bathroom before we do certain workouts, things like that. Is leakage normal during a workout or not?
It's never normal to leak urine
Okay.
or feces or gas at all. Yeah.
Okay, interesting. Now, how about this? Max effort lift. So in other words, I'm doing as much as I possibly can. Is it still abnormal?
I would say yes, absolutely. Okay. It's still abnormal. And usually so I kind of was reading, there's pelvic floor therapists, of course, that specialize in treating this population. So I was reading some articles from them, and they were basically just telling people, this is a sign that something is wrong. And it's very, you kind of have to say it's common, but it's not normal. Okay. And so when this sort of thing is happening, your body's telling you hey, something is wrong, whether it's not only your pelvic floor, actually. There can be other things going on that can cause this. But yes, I would still say even during max effort, and this is a disclaimer, I have not done that before. So I'm sure it's just crazy, athletic ability, but yeah, you shouldn't leak urine. And I also reviewing just some videos of power lifters and the the max, what's it called? Max effort when you lift the most you possibly can.
Are we talking about powerlifting? So there's 3 lifts that they'll do. One is a deadlift where there's just a bar on the ground and they pick it up and it's as much as they can possibly pick up. That's a deadlift. And then a squat would be the bar. You know what a squat is? Yeah. Same thing, max effort squat. And then the last one would be a bench press. So those are the 3. And they're all
the max possible.
Well, and during a competition, it would be as much as you can lift.
Yeah. I watched some videos and there's they literally mop up urine. Yes, that is so dysfunctional. Yeah, okay. And that's just something, your body's telling you something's wrong, and it doesn't mean you shouldn't lift that much weight. I don't know. That's a gray area, but also, you should, it's just kind of a signal telling you to try and figure out what's going on there.
So what we're thinking is that our pelvic floor should be able to support whatever loads we're putting on our body, and it shouldn't be the pelvic floor that's the weak link. If we're doing something like max effort lifting, we would call that if that's the weak link, meaning we let's say we go for a max effort and we just fail. Our nervous system can't handle it. Maybe there's a Golgi tendon reflex and we just drop it because our body's going to get injured, and it just lets go of it. And that's a neurologic process. We would call that okay. But we're saying that if the pelvic floor doesn't keep up with that, if it's the weak link in the chain, then maybe that's dysfunctional, and we would call it common but not normal. Is that kind of what? Yeah, that makes sense.
Yeah, that's what I would say. It's more that for some reason there's too much pressure being put throughout the pelvic floor. So if the rest of your body can withstand this, great command to it, something. I would have to say pressure regulation wise in your abdominal cavity, too much of it is going downward to your pelvic floor.
Yeah. Well, and you know what I've heard in the past, Sam, is first of all, as soon as this is just such a limited thought process, but a very common one I hear is, okay, as soon as a powerlifter or a strength coach or whatever, they hear, well, I don't do a lot of this, then immediately there's a line drawn and it's, okay, thanks for your time, see you later. And I just think that's ridiculous, because if we were to, if we think about this further, if you were to come in to see a physical therapist and you say, you know, every time I try to lift as much as I can, my right knee just buckles, it just fails. We would not think about that as okay and normal. In this case, not even that common, but because this is a common problem, we're dismissing it as normal, because I can tell you it is dismissed as normal. And so I think I like the idea of the analogy of that weak link, because if it was a knee, we would address it. And because it's the pelvic floor, we're like, well, okay, I guess that's just what happens when you put so much load on the body. But yeah, I'm not convinced. So to hear you second that that's helpful for me. And this brings up another question I have along the same lines of weightlifting, powerlifting. You know, are there any implications that you can think of for sort of this chronic Valsalva maneuver, this bearing down maneuver? And are there any alternatives to the Valsalva that you've seen effective? What are your thoughts there?
Yeah. So again, back to some of the reading I did to kind of just educate myself a little bit. So it's not thought to be dangerous or cause any repercussions to do the Valsalva maneuver when you're doing your max effort. But anytime you're doing like 60, 70, or 80% of your max effort, you should not be using it.
Okay.
That's what I read from a pelvic floor therapist who was, treating these patients or this demographic. So just being aware of like when you need to use it and when you can like go without using it. And just making sure you're not doing it in other parts of your life. Like if you're training your body to like do this holding pattern where you hold your breath and then you do this act, you need to like reserve that only for when you need it to perform the lift that you're doing. But yeah, I mean, a lot of people are kind of like chronic breath holders, which, you know, until someone tells you to review that pattern or habit, no one really realizes they do it. So I think for the Valsalva, I think, you know, it's not ideal to be doing it all the time, obviously, and with every single lift. So kind of working with your coach or whoever you're working with and trying to like discover when you need to use it and try not to use it when you don't need to.
Well, let's just assume that you're going to, yes, it does. But let me just make the assumption that you will need to help with that decision-making process to a degree. Again, it's kind of one of those, we've got this, we know what to do here, but then everybody's doing Kegels or diaphragmatic breathing is also in there, which we haven't discussed yet. But I'm wondering if there's an alternative to the Kegel, because I can tell you from my standpoint, I've certainly seen, I haven't seen any high-quality data on this because it just doesn't exist. However, anecdotally, there are a number of clinicians and coaches that I would consider sort of higher level thinkers that do promote the idea of, diaphragmatic breathing and then actually learning to control diaphragm during an isometric contraction. That is not the same thing as bearing down, because there's a difference between tightening trunk muscles and bearing down. So would you view that as a feasible alternative, ignoring the fact that somebody's putting the weight on their back? If you were to teach this an individual to help them with a sit to stand or whatever activities they're leaking with, picking up something from the ground, we're talking about a deadlift. And so if that's a 65-year-old individual who's not very strong, it still might be relatively a repetition maximum for them, just like it might be 300 pounds for somebody who can lift 600. So what would you teach them? And is that a viable alternative to Valsalva in your mind?
So the problem with finding an alternative to the Valsalva is that, you inhale and you hold your breath. So the natural pattern of the diaphragm with the pelvic floor is that they're kind of like, they work as a piston. That's what we always tell. There's like a piston relationship, which is like, you probably know, or you can imagine that when you inhale and you kind of use a big diaphragmatic breath, your diaphragm descends. I'll do this. and then your pelvic floor is forced to descend like this. And so then when you exhale, the diaphragm pops back up and your pelvic floor kind of pops back up too. So they're working like this. So like, for example, for someone who wanted to lift their baby and they're leaking when they lift their baby or their cat or whatever, you want to Kegel on the exhale because it's already coming back up into like a lifted position. And so the exhale or doing a Kegel when you exhale is just a little more natural and it's easier to activate when you're doing it that way. So with the Valsalva, and this is, people use this as like a compensatory mechanism when I'm teaching them how to activate their pelvic floor, is that they'll hold their breath and then like Kegel. So the reason it's so hard is because you're putting downward pressure when you're holding your breath. That intra-abdominal pressure is growing and it's kind of being forced downward. And so it's really hard to contract on when you're holding your breath like that. But I mean, I would say the key thing for like lifters is to like train this muscle group outside of lifting and like making sure it's strong and like making sure it's not overactive. Then if it is, then like fixing that problem. If not, then making sure it's strong throughout other parts of life. And I would have to look up, and I don't know if there's any data on this, but I would wonder like how many lifters who also leak in other parts of their life, like when they cough or sneeze. So I don't know if that answers your question. I don't know if there's any other mechanism than the Valsalva for what you guys need it for, but kind of like thinking of it like we need the pelvic floor and the other core four to have this like reflexive activation when it's needed. So I don't know if that answers your question.
So it doesn't, well, it does to a degree, because, and the reason I brought the question up was because to teach somebody to breathe through their diaphragm is very reasonable, but when you close the glottis and do a maximal isometric abdominal contraction, I think certain individuals are fooling themselves to think that they're doing this through the diaphragm and they're not actually doing the Valsalva. And so that's why I kind of wanted to bring this up, because I think they're teaching something, and I don't think they're teaching what they think they are. I think people are actually doing a Valsalva because they're closing that glottis and they're bearing down to a degree, but they're doing it in a way where they think they're almost like they're expanding their ribs out. But I think they're doing the same thing. They're just kind of looking at a little bit of an abnormal pattern there. And so that's the reason I wanted to bring it up, because it kind of sounds like you're saying there's a little bit of a almost like an abnormal movement pattern you're trying to teach, where these things do work as a piston together, but we're trying to teach it as no, keep this one up, this one down, and I don't know if it works that way. So I'm glad to hear your comments there. What should a weightlifter or strength athlete, what should they know about the diaphragm?
So
should they care?
Absolutely. And a lot of this kind of goes back to like reflecting on how they're using their body throughout their day, when they're lifting and doing their sport. That's only a percentage of your day. So first of all, just kind of like understanding your patterns and like how you're using your diaphragm and whether you're using it well throughout the rest of your day, right? Another thing is that it has
can I pause you there? Again, I'm from Texas. You're gonna have to help me. What are we talking about when we say using it well throughout the day, using it well, not using it well? What are we talking about?
So people just have this tendency to like breathe through their chest and not, so when you do that, you're like, your body's like, for whatever reason it's kind of compensating for some other weakness really, or I guess break in the system, I suppose. So really when we breathe, like tidal breathing, like just normal respiration, we should have like good movement through kind of like breaking it up into thirds. I like to do that, like through your upper chest, through your middle chest, like in the middle of your kind of sternum, and then through your belly. So like making sure that people like you can do breathing techniques and practice at home. Also, like the more you do that and the more you practice this, it's gonna carry on over throughout your day, and then hopefully like throughout your sport time. Does that make sense?
Sure. Yeah. So you're cutting the trunk into thirds. So are you saying that we should be able to breathe through our rib cage, kind of the top sternal area, and then maybe like the middle rib cage, and then the abdominal area? We should kind of be able to breathe through and expand each one of these, not individually, because we have the lung and that's just the size it is.
Right.
But we should be able to modify our breathing technique to not be so upper chest heavy and perhaps more abdominal heavy.
Yeah.
Okay. So exactly. Then what's the better one for the diaphragm?
So when it's like dispersed, not just in your upper chest.
Okay.
So like kind of in the whole third, breaking up into thirds, you kind of want all of them to expand together, not just like upper chest or lower belly. You want kind of a good.
Oh boy. Okay.
You want kind of a good.
We might be dispelling a myth right now. So, not from my understanding, but from my understanding of what people are saying, in order to target the diaphragm most effectively, you want to breathe through your stomach. But you're saying that's not necessarily the case. We actually want to breathe throughout all three parts of our trunk and not just isolate the stomach. Do I have that right?
I would say that's just more functional. Like no one walks around just breathing through their belly, you know?
Okay.
So in order to get good like rib mobility, the other big thing with the diaphragm that I was going to bring up is it influences thoracic mobility too. And so it's one of the biggest movers of the thoracic spine because we know it doesn't move too much, right? And so I would say like going to one extreme, like breathing through your top chest or breathing right through, like only into your belly, I would say like more symmetry throughout is better and it's more functional. So when you're doing diaphragmatic breathing practice, you can kind of play with any range of that. Like there's not anything wrong to do, I would say. Like if you're doing meditation or if you like to breathe before bed or something like that. But like just going throughout your day, you don't want your air to just like funnel straight into your belly or straight into your chest. I think just having more, this is maybe an opinion too, but just having more symmetry is more functional. And like, yeah, no one just diaphragm breathes all day, every day, you know?
Sure. Well, I like anytime we can make something more normal. I like it. It's less popular. We always want to do things in fitness that are unique and new and trendy, and that often means just something strange. But the idea of creating a normal pattern of motor behavior, I'm a big fan of that. So I like hearing anything that helps increase normalcy. But you know, that's really good. I like that a lot. So I'm also, it makes me wonder. One of the ways I've heard this described is you want to breathe into certain lobes of your lung. And I have a really hard time with that. So maybe you can help me if I'm ignorant, but I'm not sure how that would work other than to, again, maybe create some sort of abnormal, sort of muscle motor pattern where you are contracting abdominals on one side, but not the other, contracting obliques maybe with some sort of counter rotation on one side and not the other. But I don't know how you would put air into one portion or one side more than the other. I get a little bogged down with what are you talking about when that happens. So maybe you can correct me if I'm wrong and share any thoughts.
Yeah. I think when people say that, I totally agree. Like you can't inflate your left lower lung more than, the right lower, it's all just like one unit, right? I think that a lot of times those verbiage, that like type of verbiage is trying to help people expand evenly throughout. And so, I mean, like, even if you thought you could breathe through your left lower lung or lobe, lower lobe, like that's not functional. You don't want to do that all day, right?
Yeah.
So I think a lot of times, they're kind of trying to just cue people to get like more control over how their ribs and how everything's expanding. So you'll hear a lot of like even yoga practice and a lot of, you know, PTs and pelvic PTs, they'll like place their hands on the patient's lower ribs and say like kind of breathe into here and then kind of like move around and breathe into these areas. And I don't think anyone can actually do that. It's just to cue people to get more full breaths.
Okay, so what we try to mix it, because there must be something here that's going on. I would assume there'd be something helpful. So maybe in this case, you're saying the target in this case is that perhaps somebody is they're just breathing through their chest, and this is a dominant pattern for them. And maybe this is associated with like higher stress levels or higher anxiety. And so a therapist might come in and facilitate breathing. Maybe we focus a little bit more on the lower rib cage, maybe more on the abdominals, because we're just not utilizing that as a whole unit like we should. So in that case, there is something that we've deemed as somewhat abnormal that we're trying to create more normalcy. We're not trying to take what's a normal unit and then break it up and say, now you should only do left today and right tomorrow. That's okay. That helps me get a little bit more perspective.
Yeah.
Along the same lines, I don't think we have to teach anybody how to do a Kegel. They're pretty popular now. If somebody's going to try things on their own, they can try Kegels. That's very safe. I don't think there's any harm that we would cause by saying, we can try this, because if they go to the bathroom, we're not going to introduce any pressure that's considered, harmful to them. Is there any relaxation exercise that you could teach that's just sort of let's see if we can get things to relax, like we can get them to contract?
Yeah.
Okay.
I mean, my biggest go-to is actually breathing because of that piston relationship. Okay. Again, when people have overactive pelvic floors, and this is just kind of generalizing, they back to like their main function. No one knows they have a pelvic floor. And so a lot of times, like a good technique to help people start to relax and just like get more movement through the pelvic floor is just to gain better body awareness of it. Okay. So there's a lot of reasons that overactivity can happen. It's not just a big like myth is that it happens when you've had like a sexual trauma or something. I mean, that's very common in this population, but it's not, it's definitely not everyone. And I mean, it can happen from like overuse injuries or like straining to poop your whole life or something. So just like being more aware of this part of your body and just helping like reintegrate the patterns, like mind body, so kind of and that's why breathing can help, is it can help people feel like the downward movement of the pelvic floor. There's certain stretches, there's kind of cues to help people relax. So again, a lot of times with this non-relaxing pelvic floor problem is that if it does relax, it just kind of like pops back up to being tight again. And that's why it's kind of a stubborn problem. It just takes a lot of effort and energy. That's why, unfortunately, I can't cure people in one visit. It just takes a lot of repetition. So, but yeah, like verbal and mental cues. A lot of times I'll tell people like, act like you're letting out a fart, because when you do that, your pelvic floor has to relax, or like you're starting a urine stream, that can help your pelvic floor relax. So usually I start people on like nightly breathing techniques, kind of body mindfulness techniques throughout their day, stretching.
So body mindfulness techniques, is this like an emotional intelligence factor to this? Like you're checking in with how you're feeling. Are you in an anxiety state? Are you not, kind of thing? Is that what we're talking about?
Kind of, but more like on your pelvic floor. Like I'll have people throughout their day kind of send some mental energy for like a few seconds to their pelvic floor and assess whether they feel like they're holding in a fart or kind of like clenching, or whether it feels like they could let any of that tension go a little bit. So
I like that cue. I like that cue. Gives them some indication. Is this what I'm feeling, or is this not? It's kind of like, let's check the box. I like that. That's a really helpful cue.
Yeah. But yeah, it's really, and sometimes it does correlate with higher stress, of course. Like,
Okay.
you know, that's a really big, the stress response is really big and fueling this fire a little bit.
Mm-hmm.
You know, people who have this sort of non-relaxing pelvic floor dysfunction, they tend to have higher rates of like anxiety and like just life stressors, or their body is manifesting the stress physically and not like handling it mentally. So again, that's not every person, but it's really common.
Sure. So kind of like the cue of, are your ears and your shoulders when you're stressed.
Yeah.
This is a cue of, could you actually go to the bathroom? Are you that relaxed? Could you initiate a stream of urine? And that's the check-in there. Kind of like, this is the check-in up here. I like that.
Yeah. And no one thinks about, oh, I've just been clenching all day. I've been holding in a fart all day when I don't have to. It's like no one thinks of it, but it's really common, and it can ruin people's lives.
Yeah. Okay.
The symptoms of it.
You've mentioned several times myths. Are there any other myths, or we've covered a few, are there any other myths or outdated practices that you're still seeing out there that shouldn't be? Any large scale bad advice you'd like to dispel? Anything like that?
Not really. I would just, I think like what I've said is pretty common. I would say, in the age of Instagram, there's like a lot of good information on Instagram, but then there's people who have no business giving medical advice to like this, like postpartum moms is like a really big Instagram market, I would say. So I just see people having like kind of poor ideals on like what's normal or what's, every person's super, super different. So, if you have something wrong and you've tried some stuff on your own and it's not going away, like that really warrants someone helping you through it for sure. So
I like that you said that. I think it's a very human approach to say, if you've been trying these things for a while and you're not seeing success, it doesn't mean that you just have to suck it up. There is help available. I think it's just nice I think it's just nice to hear people say that, because, within certain communities which exercise has a very strong community vibe to it now. You have sort of someone in that group who's, well, I've had kids and I've read about this, so, I kind of know what to do. And what works for that individual is then, sort of introduced as gospel. And then so now all of a sudden you've got everybody doing Kegels or everybody breathing through their right lung. And if that doesn't work, well, I guess I'm just sort of, SOL, or how, and so I think that, realizing that there is help out there is very valuable to people. I think it is.
Yeah.
Any other, I think that if we would play with the idea that perhaps with this repetitive Valsalva, this repetitive bearing down, there could perhaps be some consequence to certain individuals. We'll just say that. That's very free, I think. Are there any other preventative strategies you recommend that people can practice? I think, it's easy enough for me to say things like, I think mindfulness is a very productive strategy. I don't think you have to wait till something's really out of whack to practice something like mindfulness. Are there any other strategies that we haven't covered that you'd recommend? This is something you could put in your normal routine if you find yourself saying, I'm going to stick with the Valsalva no matter what you say. I'm going to practice it with every one of my lifts because I want to reproduce the same thing every time, so that when I go to competition, I have less to think about. If that's a reality, is there anything that we could put into the picture that might help offset some of what's happening with the chronic bearing down strategy? Anything that you can think of there that we haven't already covered?
I would say there's like, just understanding there's more to it than just the pelvic floor muscles. For example, like, if you have chronic constipation or something like that, or if you have had kids and you feel like you have prolapse, just like understanding there's more to it than just muscles. And for example, for chronic constipation, some of what I was reading to prepare for this interview is that, and I didn't even really think of it, but it's that people who lift are like really high protein diets, and they're not getting a lot of fiber. And so they poop like once a week. Like that is so unhealthy. And pelvic floor therapists I treat constipation all the time.
Okay.
And it's like, think of back to this is kind of to scale, I would say.
Okay.
If you're constipated and your rectum is constantly full of poo, there's a lot more pressure on the system that needs to be there, and that can really help things. Like there's things beyond muscle. So just as far as like daily things to do, like the mindfulness and the breathing, and if you feel like you have weakness and you feel like you can do a Kegel well, trying that on your own. Just having good breathing techniques and body mechanics, which I'm sure coaches help with. But just kind of reevaluating other parts of your system, especially GI and like bladder and things like that, because those can really have an impact. And I assume just physically, mechanically, if you're like constipated, there's way more pressure there, and it could be putting pressure on your bladder, and that could be a big thing. So
okay. Is there anything, Sam, is there anything that I didn't ask that you wish I would have, or is there anything that you read about or that you've seen that you'd like to discuss?
Let's see. I would say probably in this population, strength is that's the name of the game. But just because you can lift 300 pounds in a squat or whatnot, that doesn't mean your core is really strong. Like you might think it is, but understanding that there's more complexities to it than just like your overarching strength, I would say. Like a lot of people, like a lot of athletes I see, they're strong as hell, but they have like really weak inner cores, and that's like a big problem too. So
did you say really weak intercourse?
Intercourse, sorry.
Oh, intercourse.
INNER.
Okay, I was like, okay, that's a shift. Let's cover that. Okay, gotcha.
No.
Inner core, C-O-R, gotcha.
Like the TA or transverse abdominis and pelvic floor. That's usually what we call the inner core.
Okay.
But is there anything else? I'm trying to think. I think one other thing is just that actually not a lot of people do Kegels correctly, especially if you've had babies.
Okay.
Or actually, scratch that. A lot of people don't do them well, and it's not that like they can't activate that. Like when I started doing pelvic PT, they told that to us in our courses, and I thought, does that just mean like they said that 40% of people do them incorrectly? And so I was like ready to get all these people who like bear down instead of contract. But really, I think just, people don't have good motor control, such as you need motor control of your quads to give your knee stability. You need motor control in your pelvic floor. You need proper timing, proper activation. You need activation of both those like deep levator ani group and the superficial sphincters. And if they're like off or they're just not coming online, that can cause issues too. So of course, you can try Kegels at home, but again, if people feel like weakness,
well, how do you do a Kegel? Because now we're saying we don't know how to do it. So how do you do a Kegel?
There's a lot of cues. Like we use a lot of cues because people just it's hard to feel your pelvic floor sometimes. So there's some weird ones out there, but like sometimes I'll tell people to like act like you're holding back a fart and urine. Like you have to pee and fart super bad, and then you're like holding both of them up. What you want for a good Kegel or pelvic floor contraction is you want a squeeze and then a lift. So a lot of people don't do the lift part, and the lift is what provides support. So there, I use this weird one. It's very strange, but you act like you have if it's a female, you act like you have a straw in your vagina and that you're sucking fluid through the straw into your body.
Okay, I'm having a hard time with that one. Give me one for a guy.
Like you have a marble in your butt and then you're like
Okay.
pulling it up into your belly button.
Okay.
Yeah.
Okay. So that's the lift part. So it's not just the squeeze, but it's the lift. Is there
Yeah.
anything with the abdominals happening there that should be done?
Yeah, so the transverse abdominis
Uh-huh.
fires together with the pelvic floor.
Okay. Okay.
So if you're trying to retrain someone's core musculature, you kind of
Uh-huh.
you think of both parts of it.
Okay.
Because they're kind of like, if you think of it, you know, the TA sits like a corset, the pelvic floor is
Uh-huh.
like the undercarriage. So
Yeah.
when they contract together, they're almost like cinching you up. And that's why this all relates back to leakage and lifting
Okay.
and stuff like that. Because if one is just not firing, or if it's just all wonky, it can cause you to leak urine or
Okay.
feces gas.
And then as a practice pattern, is it reasonable to say, well, between these contractions, okay, so we're saying, you know, I'm going to squeeze, I'm going to cut off the flow of urine, act like I'm holding back gas. At the same time, I'm going to try to either draw water through a straw or pull a marble up through my butt. There's that cue, so I'm doing those together. And then in addition, I'm trying to pull my abdominal muscles in, and I'm coordinating that. Is it fair to say that after that, I should be able to fully relax all that before I contract
Absolutely.
again, just as a practice pattern? Or is it
Yeah.
let's just hold it and go as long as we can? It's a
It kind of
contract,
depends.
relax?
Yeah, it kind of depends on
Depends.
the
All right.
problem.
All right. Fair enough. Fair enough.
But you should relax fully. Sorry, my
Okay.
dog's barking.
Don't
You
apologize. I
should
have so many
relax
animals. Don't
fully
apologize. Yeah.
before you contract again. And that's
Okay.
the intricacies of our
Yeah.
job, is like when you're crossing the threshold from relaxing to now strengthening, you
Yeah.
need to make sure that their muscles are all relaxing well.
Okay.
So you shouldn't walk around just like braced up like that. I mean, there's a
Yeah.
time and place for doing like 60-second holds, and that's for
Okay.
like, you know, someone who
That would be
we're
hard.
trying to
I mean, I said that would be hard. I'm just sitting here, like I'm practicing the holds while we're talking. 60, I mean, I guess it depends on how hard I'm contracting, but like
yeah.
holding all that together for 60 seconds, that
Mm-hmm.
would not be easy.
It's I reserve that. I don't make everyone do that, but
No, of course not. Okay, cool. All right. Anything else? This has been really enlightening. I really have enjoyed this conversation. Anything else that you didn't get to cover that you want to? And I'd love for you to sort of do a shameless plug at the end and just tell people where they can find you. You've been so helpful that if they want to learn more, where do they find you?
Yeah, I guess my last parting piece of evidence, or not evidence, I don't know how I said that, is just like, these things aren't normal, whether it's when you're lifting your dog or lifting 300 pounds, and no one talks about them. And even when you bring them to like physicians, they don't always take them, or they'll kind of pass them off as normal, and they're absolutely not. So just, talking to your friends, like being open with people about it. It is weird because historically no one wants to talk about sex or pooping your pants or anything like that. But
absolutely.
This is all part of quality of life, and like that's why I love my job so much, because we call it like the hidden epidemic. Like so many people have problems like this, and it's so rewarding to give people function like this back, because it's really a big part of life.
Yeah, that's an extremely important point, that we don't talk about it enough, and that so therefore it's just sort of this hidden. I'm a little bit too embarrassed about it. Do other people have this problem? That kind of thing. So that's really nice. Thank you for saying that.
Yeah, absolutely. And yeah, I work at a clinic. So the mother clinic is hand and orthopedic physical therapy specialists. And then our little subgroup is called pelvic physical therapy and wellness. So we have 3 pelvic therapists in our company. We have locations in Draper, Murray, Salt Lake, and Bountiful.
Awesome.
All of which would be able to help solve any issue. Nothing too small or too big that we can't handle.
Awesome. Okay. Well, thank you so much for your time. This has really been fun. I really appreciate it.
Yeah. Well, thank you. It was wonderful.
You have a good one.
You too.
Bye-bye.